and welcome to GBMC's Greater Living. I'm Mary Beth Marsden. I think over the past several months, if not a couple of years, we've been talking so much about COVID vaccines and booster shots, and even during this season, the flu shot. But maybe there's one vaccine that should be on your radar that isn't, and we're going to talk about that today. And we're talking about shingles. Joining us now is Christopher Toth, who is a family medicine physician assistant at GBMC Jarrettsville Family Center. Chris, thanks so much for joining us today.
Thank you so much for having me.
So I'm one of your primary targets because I am way eligible to get the shingles vaccine. I haven't done it. I've been putting it off, and I think it's sort of like vaccine fatigue a little bit. But before we get to that, let's just start with sort of the general question. People have heard of shingles, but I think there's still a lot of people out there that really don't know exactly what it is.
Sure. So shingles belongs to the varicella zoster virus family. And I want to start off by introducing it. Varicella zoster has two primary infection types. Okay? The first is varicella, chickenpox. The second is a latent viral reactivation that's called shingles. So that is what it is. Particularly, shingles is a type of blistering, painful rash. And we can get into that a little bit further, but that is how it's characterized. It's a blistering, painful rash that usually causes you to go seek medical attention.
All right, and nobody wants a blistering, painful rash. I think we can all agree on that. So in layperson's terms, the shingles virus sits dormant in your body if you have had the chickenpox at any point in your life.
Exactly.
But it's not always activated. Is that accurate?
That's right. So essentially, if you contract chickenpox, you have the typical spotted rash that goes throughout your body on the torso. We see it in children a lot. And then after that resolves, there is some residual viral material that lays dormant, and it actually goes into our sensory nerves. And within our sensory nerves, it can hang out there indefinitely, or it can reactivate later in life.
So there's a whole generation of us, if not a couple generations, who ask themselves, I don't remember if I had the chickenpox. Maybe I didn't have the chickenpox, so maybe I don't need this vaccine. What would you say to them?
Great question. And often a common question I get in the clinic. It's estimated that if you were born before 1980, the likelihood of exposure to chickenpox is somewhere in the ballpark of 98, 99%. And a lot of people don't remember if they had it because they were really young. Mom and dad never told me, or I was so young I don't even remember.
Yeah, I actually asked my mother and she didn't remember if we had it or not. So 1980, that's the marker because is that when the chickenpox vaccine came out?
Exactly. That's when around that time frames when we started vaccinating for chickenpox, and we started to see a sharp decline in chickenpox presence.
So is it safe to say that anyone who's been vaccinated for the chickenpox as a child will not get shingles later in life and is not needed this vaccine?
Yes. And one of the things that's very important to note is that even if you haven't had chickenpox, you can still get chickenpox from shingles, if that makes sense.
No,
so
can you say that again?
Yeah. So let's say you did not have the chickenpox vaccination. Let's say you never had chickenpox, but your uncle has shingles, and you happen to touch the shingles rash, the blistering eruption. That can then travel and become chickenpox. So that's that primary infection. Remember, the primary infection first, secondary reactivation for shingles.
So this would be a problem for children who have not been vaccinated, or an adult possibly who also wasn't vaccinated, who never had chickenpox. And I would imagine that chickenpox as an adult would be terrible.
Absolutely, absolutely. It takes you back to when you were younger. You get a bunch of spots all over you, general malaise, sometimes a fever, and just feeling crummy. So that's the unfortunate chicken pox.
Do we know, if we're playing the percentages, Chris, do we know at this point, percentage wise, of all the people who have had chickenpox, and that's a high percentage, right? That's believed to be 98%. What percentage of those people, if they did not get the shingles vaccine, would develop shingles? Do we know that?
That's a great question. So there's been some postulations on that. Generally speaking, between the age of 50 and 60, your risk is about 20% to get shingles, to have it reactivate in that time frame. After 60 years old, from 60 to about 70 or 80, then that doubles. That goes to about 40% chance of reactivation. After 79 in your 80th year, that goes even higher, north of a 60% in some cases.
Wow. And what are the symptoms of shingles? Because everyone says if you haven't had the vaccine, and you say you've been putting it off, let's say, someone will say to you, well, it's a lot better than getting shingles, because we've heard stories about how bad that is. But what are some of the downsides to getting shingles, and why should we get the vaccine, even if there are side effects?
Great. So, as we had alluded to earlier, shingles is a blistering, painful rash. It has some special characteristics, so we should know about these too. Shingles typically follows a dermatome. Another name for a dermatome is a nerve map. Okay, various nerves supply various spots on our skin or our body and deliver a sensation response there and receive that. So within those dermatomes is where you commonly see the blistering rash. So that is primarily the reason that somebody will come into the clinic. They'll have a new painful blistering rash that's not getting any better or even spreading.
If you get shingles, if you someone comes into the clinic and they have shingles, is it too late at that point to ever get the vaccine?
No, it is not. You need to let your shingles resolve, which generally takes a couple of weeks for all of the lesions to fully resolve, and then you can get the shingles vaccine. That is another common question I get is, I already had shingles one time. Do I need to get the shingles vaccine? There is a chance that it can reactivate again. So the answer to that question is yes, I'd recommend getting the shingles vaccination.
Is it true that if you have had shingles, you do have a higher risk of getting it again without the
It's
vaccine?
Yeah, it's actually a little bit lower. Typically, you only get shingles once, but it still can happen again. And specific situations where it might happen again, or if your immune system is depleted in any way. For example, you go on a medication that downregulates the immune system a little bit. For example, somebody who has psoriasis or rheumatoid arthritis, they're on these biologic agents that do that. Another example where the immune system might be weakened is a patient who is battling cancer or who is on several different therapies or chemotherapies.
At what age is the shingles vaccine recommended? Is it the same for everyone?
So, in significantly immunocompromised people, you can start giving the shingles vaccine once you're older than 19. However, for the vast majority of the healthy population, the time point that we start with vaccination is 50. And why 50? That is the next question that always comes up. 50, because at that point we see some degree of immune system decline. It doesn't mean that your immune system tanks the second you turn over into your 50th year, but we do start to see a little bit of decline. That's where we started collecting that data of who gets shingles and what age groups, right? So 50, we start offering the vaccine.
So is it the immune system decline that lets the shingles take hold?
Exactly, exactly. There's some stressor to the immune system, whether that be simply age related, whether that be an illness, whether that be a big life change like a cancer diagnosis or an autoimmune diagnosis, or even some medications like we talked about can reduce immune system effectiveness.
Now, the shingles vaccine is in 2 doses. Is that always the case?
Yes. Now, there was a vaccine that was offered. It was called Zostavax. It was discontinued in 2020. That was a single dose. Now, the one that is given exclusively now in the United States is called Shingrix. So that's a 2-dose series.
And this 2 dose series, obviously, it's harder to get people to come. It's harder to get them to come in once for a vaccine, and then it's doubly hard to get them to come back. But that's really important that they get that second shot in the right time period, right?
Absolutely, absolutely. And that second shot happens anywhere between 2 and 6 months after the first.
Okay, and so here's what I hear. The first shot, piece of cake. Second shot can really set you back a couple days.
It is a reactogenic vaccine, and when we say that, we mean that you can feel some body aches, you can feel a headache, you can get chills, you can feel poorly for 48 hours. That is not unusual, and also a sign that the vaccine's doing its job.
So clearly, though, if you're seeing cases of shingles in your office, which you have, I'm assuming, right?
Oh yeah.
People aren't listening to the advice or not getting the advice about the vaccine. What do you think is going on there?
Well, I think it's probably twofold. One of our jobs as primary care clinicians is to mention preventative strategies, right? So we should be talking about it. We should be talking about it when you turn over into your 50th year, about what is on the preventative care landscape. What should you be completing? So that's one thing. And sometimes individuals defer the vaccination for whatever reason in the beginning, or they want to wait. And then secondly, I think some people forget that just because I had chickenpox and it's all gone, I never need to worry about it again. We have that secondary infection, that secondary reactivation of varicella zoster, which is shingles. So there is some more work to be done, even if you get through that first chickenpox.
Do you think, too, that because so many vaccines are being required of us lately, that we're sort of fatigued of it, that we put some on the back burner and some we prioritize?
Absolutely. Absolutely.
Yeah, it's just the times we're in, right? Let's talk about now living with shingles, having shingles, being diagnosed with shingles, trying to prevent it from coming back. What happens? You talk about the rash and how it can travel around your body. Are there areas that make it really difficult to treat? What happens if it gets to your face?
Absolutely. So most cases of shingles occur on the torso, but remember, we have sensation everywhere on our body. So it's not only limited to the torso. You can sometimes see shingles on the extremities, on the arms and the legs. And then, unfortunately, you can also get it on the face. And the face is one area that becomes a little bit more concerning. We have a sensory nerve that supplies our face. It's the trigeminal nerve. And within that trigeminal nerve, we also have some branches of it, one that supplies around the eye. So if you are to get shingles that activates in that trigeminal nerve or around the ophthalmic branch around the eye, it can affect your eye and your vision, and you can get the blistering rash. So that's where we need to pull in our eye doctor colleagues, ophthalmologists, to help us out here a little bit, because it can lead to a permanent visual loss if it's not treated.
Are there any other permanent effects once the shingles is either dormant again or is gone that you might be living with? Persistent pain, for example.
So there is a condition that is called post-herpetic neuralgia, and we'll break that down a little bit. Post-herpetic, after the shingles infection, neuralgia. Neuralgia means nerve pain. So post-herpetic neuralgia is something that happens where you get persistent pain in the nerves that were affected, and the rash resolves. So that can be something that's chronic. That can be something that lasts weeks, months, that needs to be treated if it's causing a significant degree of pain for someone.
How do you manage that?
So there are a few different nerve agents and different pain medications that can be used. The first thing I do when I have a patient who has shingles is I let them know about that potential, because just when the rash resolves, that doesn't mean it's all over. It may be, and we hope that that's the case. So if you have persistent pain, we'll start with things like ibuprofen or Tylenol that can usually manage it pretty effectively. And then in more extreme cases, we have to talk about other agents that might be useful.
Are there any patients that you've seen who maybe haven't come to see you or haven't sought treatment in any way because they didn't know they had shingles? They thought maybe it was a rash from something they touched in the garden or something they ate, or maybe they thought it was eczema or psoriasis. I mean, is it so painful and so obvious that you will seek treatment if you get it?
So that varies on every person's pain threshold, obviously. Um, Most people will come in because it is a rash that is painful. It doesn't tend to itch. The other thing that patients will notice is that they almost have an area of hypersensitivity, where normal touch to that area that wouldn't cause pain is painful. So that hypersensitivity, that blistering rash, the pain associated with it, that generally brings people in. But there are some that think, well, maybe it's just a skin infection. Maybe I scraped myself and I wasn't aware of it. And that's where we come in and we kind of tease out some of the clinical manifestations and the rash characteristics, and we can help make that diagnosis.
And I'm wondering too, if it's undiagnosed, can it snowball into something else or something worse?
So generally speaking, if you didn't treat it at all, it can spread a little bit more, get a little bit larger area where you're infected with the activated virus. And then also, sometimes you can develop a secondary skin infection on top of it. You already have this blistering rash, you already have this skin opening, right? And then we can get an infection on top of it. So that's things that we all try and avoid. And when somebody comes in, we want to talk about treatments.
Do you tend to run a fever or anything with it?
Sometimes, general malaise, feeling poorly, maybe a little low grade fever. That's a common presentation with the rash.
So I know that everyone's different, but if someone comes to see you with shingles, I mean, obviously they know they have a problem and they're looking for help. How long would that individual, maybe you can give me a range, how long would that individual be out of work? Do they have to stay away from other people? How contagious is it, if at all? I know you mentioned that it could be a problem for a child who hasn't had the vaccine.
Yeah, absolutely. So the first thing, if somebody comes into the clinic and we suspect they have shingles, the first thing that I'm going to find out is how long has this been present? There's a sweet spot. We want to try and see this patient within the first 72 hours of their rash. Within that time frame, we can use antiviral medicines. Antiviral medicines slow the viral replication and hopefully reduce the intensity of the shingles outbreak. That's the first thing. Part two of that is when you have that shingles rash, it's going to vary how much pain you're in. You may need to be out of work for a period of time if the pain is that intense. And then for other people, it's no more than a 1 or 2 out of 10 pain. That's the tricky part of the whole thing. Keeping the rash generally covered once you have it is a preventative strategy to not spread it to others, because the way it is spread, shingles we're talking about, when you have those blisters, or we call them vesicles, they can actually release a few viral particles through aerosolization, and it can be spread that way. The other way it can be spread is through direct contact. That's kind of the most common way. So keeping it covered if you have it, talking to your provider and finding out if you're eligible for the treatments, the antivirals, those would be your steps.
So with the advent of the chickenpox vaccine, I mean, it would seem that in the next many years, this will be eradicated.
That's the hope. That's the hope. We're hoping to see less and less and less cases develop.